And I think that's it for now. So if you've got questions, feel free to pop them into the chat. And as the talk starts, I'll try and respond to those, or else shoot any of us an email afterwards. But with that, I want to go ahead and get us started. The main reason we're here. So I've put Vikrant's bio up on a slide. You probably have gotten multiple emails from Liz that contains his bio. His bio is on the website. And personally, I find it extremely uncomfortable to be standing there awkwardly while someone reads my lengthy bio. So I'm going to allow you all to read the lengthy bio. And instead, I'm just going to share how pleased I am to have Vikrant with us. So Vikrant and I are actually academic siblings. We have the same PhD advisor, although at slightly different times. So I think I was really out of the house by the time Vikrant was academically born. But we managed to connect quite a bit through our advisor, and obviously our research topics were very similar, and through conferences. And in fact, about 1.5 years ago, I was at a conference and chatting with Vikrant about some possible collaboration ideas. We were planning a fall visit for me to go to Dartmouth and do some hiking in the New Hampshire mountains and start doing an interesting research project. And instead, Vikrant is here by Zoom, but one of my academic children is now his academic child, which again, just makes things very confusing. But I'm delighted that Ishu, who's going to be starting his PhD program, I guess technically has started his PhD with Vikrant, is already in New Hampshire. And so he's representing Michigan out there. But Vikrant is a great scholar and has done some really interesting work across a number of fields. And so when he agreed to give this talk, I was just delighted. And with that, I'm going to switch my slide over to him and let him begin. So thank you again to everyone who's joining us. Please put questions in the chat. And most of all, thank you, Vikrant, for taking some time with us on this very strange first day of classes.
All right, thank you so much for that introduction. Hopefully everybody can hear me, even though I'm yet to share my slides. Now let me give it a try. Okay. So do you see my screen, but nothing really useful there? Okay, great. All right, how about now? See something? Okay, great. Thank you very much. All right, so as I was telling a few minutes ago, this is my second time ever trying to give a Zoom talk. So at least this is not my first time. So that's the good news. And also, you guys are all going to be my guinea pigs because I start teaching my online Zoom classes in about 2 weeks from now. So that's how I'm treating this talk. So having said all that, it's an absolute pleasure to be here, even though I would have much more liked to be there in person to give this talk in a different kind of world situation than this. But nevertheless, I'm very happy to be giving this talk on Zoom. And today I'm going to talk about some of the research that I did along with some of my collaborators here at Dartmouth College about a couple years ago. And the title, as you see here, is a simulation-based comparison of point of care testing and central lab testing. And this is joint work with Reed Harder, KG Wei, and Dr. James Stahl, who's my close collaborator here at Dartmouth. So I do want to talk about all these things in a few minutes, but I just thought I would give you a really quick overview of who we are and what we have been up to the last few years here at Dartmouth, just to get sort of some background set. So what we have here is what we call as the Operations Research Group that I lead. And we are, apart from myself, there's about 6 PhD students right now with Ishu joining. And then we have a bunch of master students and a bunch of undergraduates. And what we do here is essentially applied operations research. And there are 2 main application domains. We work in transportation areas and we do some work on healthcare side, which is what I will talk about today. And specifically, we do things like schedule design, network planning, disruption management, pricing, consensus building and group decision making, predictive diagnostics, etc. And from a more sort of modeling and mathematics standpoint, we do a lot of optimization, like integer optimization or optimization under uncertainty, but also some other mathematical models, including game theory and mechanism design, applied machine learning, simulation modeling, which is what I will talk about today, And also we spend quite a bit of time trying to develop better and faster and more efficient algorithms and heuristics for solving all these math models. And we are very grateful for the support of our research sponsors, which have included National Science Foundation, Department of Defense, National Institutes of Health, Federal Aviation Administration, World Wildlife Fund, as well as some of our industry sponsors, including Laminar Aviation and Maersk Liner Shipping, etc. All right, so that's a little bit about us. Now let's get started with today's talk. And before getting into the technicalities of that, I want to acknowledge that, as I said before, this is joint work with two of my PhD students, actually two of my very soon to be former PhD students. So KG Wei already graduated last summer and he's working in the industry now for a few months. And Reed Harder is supposed to be defending his thesis in a couple of weeks from now. So he will also be soon a former student. And Dr. James Stahl, he's what I call as a real kind of doctor. He's a medical doctor over at the Dartmouth Hitchcock Medical Center. And he's actually a section chief of the General Internal Medicine there, and also an associate professor at the Geisel School of Medicine at Dartmouth College. And so we all worked on this research topic and published a paper together in a journal called Medical Decision Making, Policy and Practice last year. And I think that's the one that I shared with you guys. If you need a copy, just let me know. I can definitely share it with you. But that's going to be what I'm going to talk about today. And we are very thankful to the National Institute of Biomedical Imaging and Bioengineering, which is part of NIH, and also the Consortia for Improving Medicine with Innovation and Technology for their support for this research. All right, so with that, let's actually get started with the talk today. And even before I talk about what we did, I just wanted to relate it to the ongoing situation a little bit. So as I said, we did this research a couple of years back. So when I decided to start making my slides last week, I thought, let's look up some of the headlines. And so the one headline that I came up with was this FDA news release. And there's a lot of text here. I don't want you to start reading all this, but this is dated August 26, 2020. So that's 5 days ago. And it talks about FDA authorizing a diagnostic test where the results can be read directly from testing card. And so there is a lot of things that it says, but I want to highlight some specific parts of it. It talks about how this new test is fast and the results can be obtained in minutes, specifically within 15 minutes or so. And then it talks about how the test is very convenient. It says that the provider can read the results directly from the testing card, and the fact that the test can be conducted at many different places, such as the doctor's office, emergency room, schools, etc. So convenience seems to be an important part of this release. And then it talks about how the test is very specific, which means that there is not too many false positives, but it's not very sensitive, which means that there's likely to be some false negatives. So what are we saying here? We are saying that speed, convenience, false positives, and false negatives are some of the important aspects of describing this test. Now, this is not just about this particular press release. If you look at some of the headlines on COVID these days, you will see these same trends being talked about over and over again. So if you look at some other recent headlines, for example, a couple of weeks back, CNN reported about this new saliva-based COVID test, which is supposed to be, they say, a game changer. And the two things that they say are that the test is fast and cheap. Then there is a Boston 25 News article talking about at-home coronavirus test kits. So clearly convenience is an important factor here. And then I don't know if you guys followed this, but there was this big news that 77 of the NFL, that is National Football League, players tested positive earlier this month, I think, for COVID. And that kind of started, the whole league started unraveling. And then they later came back and said, no, this was because of what they called as isolated contamination. And these were actually false positives, all of them. So that's what CBS Sports reported again last week. And this is not just a domestic situation. Even internationally, there have been a lot of false positives. For example, Sweden found 3,700 false positives reportedly as reported by medicalexpress.com. That was also last week. And then as far back as 3 months ago, Johns Hopkins Medicine warned us against a lot of false negatives that can happen in a lot of diagnostic testing for COVID. So again, you see speed, cost, convenience, false positives, and false negatives as the 5 continuous themes here. So it seems like what these headlines are saying is that a good diagnostic test should be fast, should be cheap, should be convenient, should have not too many false positives, and should not have too many false negatives. This sets us up really nicely for what I'm going to talk about. And those are actually the 5 things that we focused on in this research project, which happened pre-COVID, obviously. All right, so let's step back and start in a more kind of traditional fashion. So you've seen this kind of statement many a times that US has one of the highest per capita health expenditure. And here it says that among the Organization for Economic Cooperation and Development, which is OECD, US expenditure is the highest, and yet the outcomes are not the best. In fact, there are some significant health challenges. This is a well-known fact. People have talked about this, and people have talked about all kinds of ideas to try to fix this situation. So in particular, some people have talked about things like, how do we produce better quality care at reduced cost? And some of them talk about shifting the focus to what they say is a more patient-centered approach toward earlier care. And they say that this will allow not just better outcomes, but it will also allow us to reduce the usage of more expensive medical resources, and they can be reserved for more complicated patients. That's the general rationale, which makes sense. So there are a lot of new delivery models that people have talked about, and they are making patients more and more sort of front and center in the decision-making and the self-care process. So this is where things get interesting, because these kinds of models often require the development of inexpensive and easy medical devices and information sharing tools at the point of care. So being at the point of care has some obvious advantages, clearly. And the NIBID, the National Institute of Biomedical Imaging and Bioengineering, they recognized this way back. And so they established a Point of Care Technologies Research Network, or POCTRN, in 2007. All right, so that's a lot of clinical information, but then, I'm not a clinician, not by a long shot. I have no formal training in healthcare. So, why do I come into picture here? Why should I come into picture here? Why should many of you guys who are maybe in the same situation come into picture? It turns out that there is something that we work on which could be relevant, and that, in my opinion, is the systems engineering perspective. So one thing to note when trying to evaluate or trying to talk about the value of a technology such as point of care technology is that we cannot say in a blanket sense that point of care technologies are good or bad for so and so reason. What often matters is the context or the setting in which we are talking about. So technologies do not exist in isolation, but they are often to be thought of as a part within a system of other technologies. So whether or not a technology is successful or it fails is not typically a binary question. It's a question of when is it applied, where is it applied, how is it applied, what is the context, what's the setting. And so in order to try to understand that, the national academies long recognized this, and they called for the introduction of systems engineering tools or operations research tools, as some of us call it, into healthcare to solve these kinds of problems. And so that's where us industrial and systems engineers come into play. And POCT is in particular a great place to talk about some of these ideas, because POCT can be potentially disruptive. POCT is point of care testing. It can be potentially disruptive. It can change where, when, and how of the care delivery. And so it's a great place to talk about the systems engineering perspective. So that's really what we are going to do today in this remaining several minutes. All right, so let's talk about why should we focus on diagnostic testing. I talked about this large healthcare budget But it turns out that only 4% of that is attributed to testing. So maybe testing is not that important in that sense. However, it turns out that testing changes a lot of the downstream workflow, and it influences patient outcomes and patient flow and a lot of other big picture things. And hence, it turns out that about 2/3 of all the hospital budget is affected indirectly by point of care test, by diagnostic testing in general. And so improvements in this testing area can potentially bring large benefits downstream. So what is point of care testing? It's exactly what it sounds like. It is testing which is close to the point of care. So instead of the sort of conventional setting where you take some samples, either you take the samples in a faraway central lab, or you take them locally but then transport them to a faraway lab for analysis. Unlike those situations, POCT involves taking the sample, analyzing it, processing it, doing all that stuff locally where the care is to be delivered. So on the right hand side, you see a slightly exaggerated take on conventional lab testing, where it says that the sample is collected, then it's transported to a place where it can be looked at. Then it is looked at, then it is, some numbers are reported, then they're filed, then you call the hospital, you call the patients, you deliver them the news, you tell the same thing to the primary care physician, and then you file everything away, store it in records, and you're done. So that's sort of the way central lab testing works. On the other hand, POCT, you see this little device there. So it's supposed to collect a sample, analyze it, process it, and give you back the results right then and there within a few minutes typically. So that sounds great, right? In fact, there is empirical evidence that this actually does work much faster. There is empirical results that say that the turnaround times are much smaller than central lab testing. That's not surprising, that's expected. So there is a tremendous potential for using POCT, and it's pretty common in Europe and growing rapidly in US and many other parts of the world. In fact, in 2006, a study reported that the POCT method of testing is supposed to grow at the rate of something like 15% per year, which is, I think, in the ballpark of what has been happening. And there are widespread applications of this. There is applications in many different physiological systems in many different parts of the body and many different medical conditions, including streptococcus, HIV, pregnancy, blood glucose, malaria, cardiac biomarkers, drug screens, cancer, hepatitis C, stroke, syphilis, and of course, COVID-19. So there is all kinds of different medical conditions in which you can potentially use POCT. So it's faster, it's growing rapidly, and it's useful in many, many applications. So it's a no-brainer to use it whenever possible, right? What can go wrong? Turns out that it's not that simple. There are some downsides to POCT. One downside is that typically it costs more just to administer the test. For example, for creatinine test, a study showed that it costs about twice as much to do it in a POCT setting compared to a central lab setting. So that's something to think about. Another challenge is that there is typically lower quality and sort of higher error rate associated with POCT. So there are studies demonstrating this higher error rate, and there are a lot of possible explanations, such as insufficient sample volumes or provider errors. Now, the technician who collects the sample in a central lab setting is typically more trained to do that as compared to the folks who deliver care in a POCT setting. There's also more process control at the central lab. So these are some of the reasons why central lab ends up being less error prone. And interestingly, a big advantage of POCT can be a disadvantage as well. Short turnaround times sound great, but they also reduce the opportunity to correct for errors that may be identified later, right, before you jump the gun. So that means what we have learned so far is that on the one side, POCT has faster turnaround, and that's helpful to start the treatment early. but then there is higher cost and lower quality. On the other hand, central lab has slower turnaround, but economies of scale can give you lower cost, and process control, better process control can give you higher quality, among other reasons. And this has been confirmed by past studies. One study found that when it compared POCT and central lab testing empirically in terms of patient outcomes, it found that sometimes POCT delivered better outcomes than central lab, and sometimes central lab delivered better outcomes than POCT, which means that there is no clear winner here, at least in terms of patient outcomes, based on what this study found. So that's how the literature looks like. There is a bunch of studies on empirical evaluations. As I said, they show the obvious part. They show that there is reduced turnaround times, but they also show mixed patient outcomes between POCT and central lab. And then there is a relative lack of clinical simulation studies. There are some studies. For example, one study looks at the impact of test turnaround times on the patient flow, and they find that lower turnaround times are better for patient flow, of course. And then another study looks at POCT itself and says that POCT does improve the patient flow in an emergency clinic. Again, this is useful, but not the complete picture, because nobody's looking, as far as we are aware, nobody's looking in a simulation way to try to understand holistically, in a more comprehensive manner, the overall trade-offs associated with using POCT. So there is little attempt to evaluate trade-offs in cost and quality, or to evaluate them under various clinical settings, and to look at outcomes and societal costs in a more holistic way. So that is exactly what we tried to do in this study. So now talking about what we did. So we developed a discrete event simulation model using Arena software language for a holistic comparison of what we call as different testing regimes. And we looked at patient flow, outcomes, treatment costs, testing costs, etc. Here's a little sneak peek at what this simulation looks like. And it basically follows the patients through their entire cycle, through their entire movement through the clinical system. So I'm going to tell you a lot more about this simulation in the next few minutes. First, let me tell you how we got to making a number of decisions that we had to make. So there were, you can imagine, for designing something like this, there is so many parameters that need to be set, and so many assumptions need to be made. And every time we made an assumption, that made us suspicious about the assumption. So we had to revalidate it and recheck it and think about how that can break something else later downstream. So what we did is we relied very carefully on, direct observation, as well as expert knowledge, as well as a number of studies in the healthcare delivery literature. For example, one study we relied on was this national survey of the Society of General Internal Medicine. Another one was a national ambulatory medical care survey. And then there were a bunch of studies on real-time location systems, or RTLS, in healthcare delivery. Even after all this, we still found that there were places where we could not find realistic data to fit our distributions. And so we often relied on the tried and tested triangular distributions whenever we could not find something more sort of validated by data. So we relied on all these sources, and then we realized that we're making a lot of assumptions. So we did a ton of sensitivity analyses to make sure that our main findings and conclusions are robust to the assumptions and the input parameters that we used. All right, so let's get started. Let's dig deeper into what we actually assumed. So let's start by understanding the different types of patients that we simulated. The patients, some of them had the underlying target illness and others did not. That's the point of testing, right? And then some of the patients were new patients, others were established patients. Some of them had severity level low, which is number 1, medium, which is number 2, or high, which is number 3. So for all these different types of patients, we found our data from these past studies, and then we fitted to it normal distributions in most cases, and we found all these different distributions for each type of severity level, each new versus established patient, and then we also use the same process to fit the patient exam times and also the time to fill out the paperwork. So we basically got distributions of all kinds of times, which is a very important thing in a discrete event simulation, the time spent in different steps. All right, so then we also had to decide some very important probabilities here. These were really important choices we had to make. So we set the probability of having underlying illness versus not having the illness, and also the probability of being tested versus not being tested positively. And they were both correlated with severity. In other words, as you can look at the bottom here, as you go from severity level 1 to 2 to 3, we had an increasing probability of the patient having the target condition. It monotonically increased from 0.2 to 0.4 to 0.75. And then the probability of testing the patient, it should also increase with severity, right? If a patient looks more severely ill, they're more likely to be tested. And just a comment on what this severity level means. It is an indicator severity. So this is measured based on symptoms as well as other factors such as patient history, family history, pre-existing other conditions, comorbidities, and so on. So that's what we used to figure out the severity of the patients. And then we established these probabilities. All right, so let's talk about the three testing regimes that we looked at. So we already talked about POCT, which is point of care testing, and we have talked about central lab, which is central lab. And then the third case that we also want to highlight here is POCA, or point of care sample acquisition. So let's start with that one, and let's make sure we understand its workflow first. POCA here means that the patient goes to the point of care to get tested. The sample is collected right there in their primary care physician's office, let's say, or at CVS. And then the sample is sent by transportation to a central lab where it is processed and the results are delivered. POCT is where the sample is, again, as you already know, the sample is collected in the doctor's office, analyzed right there, and the results delivered right there within minutes. And then central lab means that the patient goes to another place where the sample is collected in a central lab, then it's processed right there, no sample transportation, and the results are delivered. So we are going to focus on these three types of testing regimes, we call it, and we are going to compare and contrast between their effectiveness. All right, so then we also have three clinical settings or clinical scenarios that we are going to look at. The first is rural, the second is community, and the third is hospital-based. They are sort of catch-all phrases to represent the distance between clinic and the central lab. So rural typically would mean that the standalone clinic is far away physically, geographically from the central lab location. Community means community clinics that are, again, standalone clinics that are not in the same location as the central lab, but not terribly far away perhaps. And then hospital-based is where you have one big hospital that has the clinic as well as the central lab all co-located in that same complex, so to say. So what we said is for rural, let's assume that, and this is again backed up by literature and so on, let's assume that the patient transportation follows a triangular distribution in terms of the number of hours needed, and the minimum is 8, mode is 16, and maximum is 24 hours. And the same for the sample transportation for POCA. With community, these numbers are smaller. So we have 2, 4, and 6. So that's all 1/4 of the values for rural. So much closer, but still not trivial. And the same here. And the rest of the numbers are similar across the scenarios. And then hospital-based is another almost an order of magnitude smaller compared to community, which means that the numbers are like 0 to 1 or 2 hours at most. So you can imagine everything co-located. It's just a matter of somebody just walking over to some other place to deliver the sample, or the patient walking over to the other part to get tested, etc. Okay, so then let's talk about errors. And sensitivity and specificity are going to be used as the main proxies of quality. And here are the numbers we used. Let's stay focused on pneumonia, because pneumonia is the one that I'm going to present the results to you for. But then we also looked at 3 other conditions in a lot of details. So in pneumonia case, we found that literature says that the POCT error rate is about 20%, both in terms of sensitivity and specificity, while it goes down to 5% for all the other situations like POCA and central lab. And then we also have the per patient treatment cost listed here at the bottom. Of note here, look at the opiate test. For the opiate addiction, you see that things are kind of similar. The POCT sensitivity and specificity is a little less than pneumonia, but then the treatment cost is much higher than pneumonia. And then for chlamydia, you see the numbers are really similar to pneumonia. And then finally, for cholesterol, the numbers are actually quite a bit different. The costs are similar, but all the numbers across the board are much more accurate. But then especially more accurate are the POCT numbers compared to pneumonia. And I'm going to talk about how all this translates into our results and the relative effectiveness of POCT versus central lab. We also measured as a very important matrix in our analysis the amount of time that the patients lose. After all, POCT is supposed to come back faster, which means that it is supposed to save us a lot of time. So the patient who tests positive for an illness gets treated, and those who test negative don't get treated. That's what we assume. And then even after being treated, they need some time to recover. And if they're not treated, they still need some time to recover from the indicator severity. And so that accounts for the work days lost. And that depends on 3 things. One thing is the severity. More the severity, more the time to recover. Underlying illness or not. If they have the illness, then that takes more time to recover than not having the illness. And then treatment. If they do get treated, and if they have the illness, then it takes less time compared to having the illness but not getting treated. So what all this means is that we have all these numbers coming from the prior literature mostly. So first, we talk about the cases where the target condition exists, which means the patient is actually sick with pneumonia or whatever, and they get treated, and they have 3 different severity levels. So here you find that for pneumonia case, the distribution is discrete distribution, where with 50% probability, there is no time loss. So the patient is pretty quickly recovered. By the next morning, they are good to go to work and so on. And then with half the probability, you need another day. And then it gets worse with severity. And then if they're not treated, of course, it gets worse compared to being treated. And then finally, if they don't have the target condition, then it doesn't matter whether they are treated or not. That's an assumption that we make. You can imagine that the treatment could potentially have some downsides if they are not having that illness. But in this simulation, we ignore those. And so we have another bunch of distributions for the amount of time lost. These are all measured in days, by the way, number of days lost. And then in case of pneumonia, there are 3 kinds of tests that one can do. There is blood test, x-rays, and urine tests. And so for different level of severity, we consider different probabilities of ordering different tests. So all 3 tests are ordered not very often for the lowest severity, but then more often for the medium severity. And by the way, we assume that if people are really, really sick looking, then the doctor will order the test and also treat the patient right away, so as not to lose time in these people who are looking like they really need help. So that's another important assumption that we make based on guidance from our clinician friends. And then we got the test costs calculated for every possible regime and for every possible type of test. And all these are in dollars. These are all directly from the literature. This is the easy part of the parameter gathering. All right, so this is how our overall simulation looks like. We have 6 modules in this simulation. Let's walk through them quickly. First, patient arrival module, where the patient comes in and checks in. Then the waiting room module, where the patients go to waiting room area and wait for the nurse to come in. Then the triage module, where the nurse comes in and checks whether the patient needs to be sent to ED or not. If not, then the physical exam module, where the patient waits for the doctor comes in, the patient goes to the physical exam room and then gets examined. And then comes the big important part for this simulation, which is the lab work module, where the whole POCT, POCA, or lab testing, central lab testing, all those procedures reside inside this little square here, the testing strategies square. And then finally, the patient departs from the clinical system after having tested, treated, or not treated, whatever it may be the case. So that's the patient departure module. So that sets us up for this simulation, which we ran for an entire year, 120 times, which means that 1 year is supposed to consist of, in our estimates, it's supposed to consist of about 240 work days, roughly corresponding to 52 weeks or so. And then we ran this entire year's worth of simulation 120 times. And the goal there was to make sure that the standard deviation of our important output matrix is not more than 5% of the mean. That's how we felt comfortable that we can trust the results in terms of the simulation output variability. All right, ready for results? Let's get started with the obvious ones. So let's look at the average amount of time spent in clinical system. So this is a no-brainer, right? POCT should be the best one here. That's sort of the point of doing POCT, that you get back the results really quickly. And indeed, it is the fastest one in all regimes. And central lab is the slowest. Well, central lab and POCA are slower than POCT in both regimes, in all regimes, sorry. But then interestingly, the difference is extremely amplified in the rural case, as expected. And it's the least in the hospital-based case. So there's still a difference, there is still an improvement, but not as much in the hospital-based case. Okay, so these are numbers in hours saved. So now let's talk about some of the other performance metrics. So let's talk about the subsequent productive days, you know, of work or leisure or whatever that are lost because of the illness. So again, we are going to focus on pneumonia here, and for POCT, we see that the amount is 1.73 as against 1.52 days. This is days on average for POCA and central lab. Why do you think POCT is a higher number across all regimes? Remember, it has the least, it has the highest error. So sometimes you don't treat the patients that you really should have treated, and that contributes to the increased average time lost. So we have between this slide and this slide, we have the time in the clinical system and the productive days lost after exiting the system. Next, we combine these two tables to come up with the overall measurement, which is the total productive hours lost, both in the system and after exiting the system. And you will see that again in rural case, there is a dramatic benefit of POCT. POCT actually, you lose almost half of the amount of time you lose in POCA and central lab testing. The benefits are much less in community setting, and actually the directionality is flipped for hospital-based, where you actually see that POCT is worse in terms of the total time lost by just a little bit. All right, now let's combine the amount of time lost with the treatment costs and the testing costs, and let's see what that gives us. So I'm combining the results on the previous slide, which is the average direct cost per tested patient, which is the time cost plus the actual cost of testing plus the actual cost of treatment. So you have testing cost, time cost, and treatment cost. The testing cost is easy. We just got that from the literature. The treatment cost is kind of interesting. If you look at it, you see that POCT has a highest cost for false positive treatments, because you sometimes treat patients you don't want to or shouldn't have treated. And then the true positive treatment costs are actually lower because you don't treat the patient sometimes that you should have treated. So overall, it sort of evens out, it turns out. And so the total effects are here. These are the combined effects of everything, like a much more comprehensive evaluation. And you see that in the rural setting, POCT is still easily the winner, but the margin is not as dramatic. It's not twice as good or half as bad as others. It's a little less than that. And then community setting, you still see POCT as the winner, but by a much less margin. And then hospital-based setting, you actually see that POCT is the worst, at least for the parameters that we looked at, by a little bit. So are our parameters accurate? Let's try to look at some of the sensitivity analysis that we did. First, let's look at the effect of wage rate. So as the wage increases, it favors whichever strategy, whichever testing regime has the least productive hours lost. So in case of rural setting, POCT has less time lost. So as the wage rate increases, it favors the POCT more and more, while the directionality is flipped for the hospital-based setting, where POCT was not as good in terms of the hours lost or the days lost, and then it gets even worse with increased wage rate. So that's what we find here. Increasing wage rate enhances the advantages of lower lost productive hours as compared to the test cost and treatment cost, and it amplifies the advantages of POCT for rural and amplifies its disadvantages for the hospital-based scenario, which is expected. Now, we found somewhere earlier, you saw that literature said that the current POCT costs are in the range of about $300 and something for the actual testing. What if we can come up with cheaper POCT, as many scientists are trying to do that for many diseases? It turns out that our sensitivity analysis can identify the range in which POCT starts beating the other two regimes, even in the hospital-based setting, which is the least advantageous to POCT. So it turns out that there's a number somewhere between $260 and $280. So if we can reduce the cost by about $50, $60, then POCT will be actually better even in the hospital-based setting as well, compared to the other two regimes. So that's quite interesting. That gives you motivation for inventing cheaper POCT technologies. And then if you look at sensitivity analysis to the other conditions. So let's focus on opiate addiction. And in this case, the main difference, as you may recall, is that the test quality in terms of sensitivity and specificity is a little bit worse. And the treatment cost is much higher than pneumonia. And in this case, what you find is that POCT is actually worse even in the community setting. In the middle column also, POCT starts losing out. Why? Because the lower sensitivity specificity means that you might end up giving treatment to people who don't need it. And now that the treatment is more expensive and the error rates are higher, POCT starts looking less promising for opiate addiction case compared to the pneumonia case. And then finally, for cholesterol case, where all tests are more accurate and POCT are especially more accurate, we find that POCT actually performs the best in all three scenarios. So even in hospital-based scenario, because POCT sensitivity specificity is as high as 90% as per the previous literature, it means that POCT just wins, period, across all situations. All right, so last slide. What are the takeaways that we have here? First, simulation framework is pretty effective for evaluating these different trade-offs. And you can see the value of doing this sort of very systematic, very thorough analysis on several different dimensions. And we essentially identify some of the same trade-offs that empirical work found out, that the clinical setting matters a lot. Whether to use POCT or not is not the question. The question is, when should POCT be used and when should it not be used? What are the factors that one needs to take into account in making that decision? And there are a lot of limitations. For example, we ignore things like staff utilization, clinic revenue, which could potentially be incorporated. We make a lot of assumptions about parameters, which are, I think, accurate for our settings that we looked at locally in our area, but they may or may not be very accurate from some other sort of settings perspective. And we are also not modeling the longer term kind of patient health outcomes, which can also tilt the balance in favor of one or the other. And so there is future work that is needed and is ongoing right now, some of it in our group, where we are trying to expand the flexibility, scope, and accessibility. And the goal here is to empower the people making these decisions to actually look at their specific setting and their specific parameters and try to come up with their own decisions on what works and what doesn't work for them. Let me stop here. I'm sorry I ran out over a little bit, but I'm happy to take any questions and stay here a little longer if necessary. Thank you.
Thank you, Vikrant. That was wonderful. And so, of course, you're not getting any feedback from us, but there are just roars of cheers across all of Ann Arbor that I can hear out my window. So, Renata, maybe you can take some. Thank you, Liz. Renata, if you can offer some of the student questions, and for the audience, if you have a question, we can unmute you. You can simply type in just a question mark or a C for a comment into the chat so that we can open this to the audience.
Sounds good.
We can unmute Renata. Oh, you're unmuted. Good.
Oh yeah. Do you want them to ask the questions themselves, or should I just read them?
I think you can, for now, you can do a couple, and then as people would like to volunteer some questions, they can just enter into the chat.
Okay. So I had a question. There was a question that was submitted that asked, I was wondering if you or someone else have looked at the relationship between the testing regimes and how frequently someone does not get tested or delays a test, i.e. someone who lives in a rural area needs to get a central lab test, may delay / choose not get tested in areas in the POCA and POCT regimes. They will test it on site, and the potential personal and societal costs of a delay / not getting tested.
Yeah, that's a great question. Actually, that's one of the things that was discussed quite a bit in the review process of the paper, because we know for a fact that sometimes from personal experiences, people don't do exactly what they are told, and that could be because of just physical problems like just not having accessibility to a central lab, or also because of behavioral reasons. You just don't want to do that, right? And that actually interestingly depends on the type of condition as well. Like if it's pneumonia, I probably will do it as against, I don't know, something else where I feel more reluctant. But with pneumonia, I want it to go away right away or something like that. So I think the long story short, there are studies that have looked at what we call as balking behavior by the patients, and we did include it in our study, but we did not customize it for conditions, and that's something that one can do with better data. I think our study assumed, if I'm not mistaken, around 3% balking rate, and that does not change things tremendously, but you can imagine if that's like 20% or something, that can just totally change the numbers there.
Thanks, Vikrant. There is a question in the chat about decision makers having reservations with simulation. And I want to expand that question a little bit and ask you, first of all, how did you find this collaboration? How did this project get started? And then what are the things that you have had to teach your collaborator to get them comfortable with your work?
Yeah, so I should say I'm very, very fortunate on both those counts. So the way the study started was fascinating. It's like a typical Dartmouth situation where I went to talk to somebody else, and then we had a nice chat and nothing came out of that. And that somebody mentioned to somebody else that, hey, there's this guy who just joined engineering and you might want to chat with him. And so I got that email in my inbox saying, let's talk. And so that's how it started. So zero credit to me, all credit to my collaborator. But since then, it's been great. We have been working on this and a few other topics. And so Dr. Stahl is actually somebody who knows simulation quite well. He is less of a researcher in this area, but he has quite a lot of understanding. So that's good. We have been trying to work with other doctors, and there is more translation necessary because people don't necessarily have that background. But from my collaborations with him as well as a few other doctors, I would say that simulation actually, and Amy, you can maybe tell me if that's right or wrong, but my limited experience suggests that simulation is actually a little more palatable compared to trying to talk about some large-scale optimization problem or whatnot and showing a bunch of equations and saying that they reflect the reality is a much harder sell for good reasons. Than showing them a simulation where the patients are moving through the system, especially if there is a nice visualization, and then they can actually look at it and tell you if this makes sense or not, right? I mean, of course, we can keep debating about the exact parameters, and that's a debate we need to have, but I think in principle, it makes a lot of intuitive sense to a lot of practitioners and is, I think, one of the benefits of simulation in any kind of setting, healthcare or otherwise. So yeah, it was easier than maybe some of the experiences I've had with other collaborations with industry folks.
Yeah, I agree that relative to things that feel a little bit more like a black box, it can be an easier sell. And at a minimum, many of our clinical partners have at least some statistical training. They're used to hypothesis testing in their research. But I think it's also, especially I like the fact that you're able to show some visualization. I think simulations are a really valuable way to help show our clinical partners that planning to the average or planning to the mean is problematic. And I think simulation allows us a way to kind of demonstrate that a little bit more clearly. But nonetheless, it does require some education. We have time for a few more. Liz, I don't know about you, but I'm having trouble unmuting people. If you can either unmute Catherine Irwin and let her ask the question, and if you can't unmute her, then you can ask it for her, please.
So I think I'm unmuted. This is Catherine. Can you hear me?
Oh, good.
Okay. Yep. So I think that my question, it goes back to this, it's problematic to plan around the mean. And I'm not familiar with simulations, but we've seen with the COVID testing that there have been a lot of problems with availability and costs for the various reagents. And I'm wondering about how you might be able to account for or attempt to account for variations in cost or simple availability, supply chain issues in a simulation like this.
Yeah, so there is a number of aspects to cost. I think the costs that we did look at included essentially one, which is the cost of time of the patients, and then some numbers that we pulled out of literature on testing costs and treatment costs. But yeah, you're right. You're absolutely right that there are some interesting issues. Actually, I was chatting about this with our local hospital, and there is some very complicated supply chain challenges associated with the PPEs and other supplies for COVID. This work was pre-COVID, so we didn't know what COVID meant back then. But so we ignored those things in this research. Now, but I know that that's not your question. Now, I do see a fairly clear path to incorporating supply chain uncertainty issues into this kind of simulation. In fact, that's a direction we contemplated in the last few weeks. That's a direction we thought of going, and we might still. But I think it would be, in sort of off the top of my head, I would say that it would probably make sense to simulate the supply chain itself, and there's going to be a different kind of little moving piece there in the visualization, where the moving pieces would be the supplies that come in, and that's the best I can think of right now. I don't see why simulation can be used, but it definitely requires quite a lot of more thinking, and it probably may not make sense for all disease conditions, but it might make sense for COVID context.
Well, your answer just made me think about it differently, so thank you.
Great.
And Michael, would you care to share your question with us, please?
Yeah. So my question is, if you know of any research that's looking at disease progression over the space of time that it takes to retrieve the test. So example with COVID is whenever the first test came out, I think it was about a 2-week turnaround of the test, and by that point, in the case of COVID, they can infect many other people, or in the case of something like pneumonia, the patient's health condition could deteriorate significantly. So.
Yeah, no, that's absolutely true. And actually, that's one of the limitations. You're spot on. The disease progression part is not really modeled here. What we do in this research, as I said before, is that for the high severity cases, we just assume that the treatment happens right away because that seems to be somewhat consistent with the protocol. And so we kind of cover for the worst cases, but then I think disease progression is something that is so condition specific that that should be here in the limitations section, I would say. And I think it can be modeled. Again, we need some data, and with some effort, we probably can find some in the medical literature on how the disease gets worse with probabilities associated with that in the absence of treatment. And ideally, to be honest with you, it's not just disease progression. We had talked about this early on when designing this model. You know, disease progression is important, and then the potential revisit of the patient to the doctor in some way, shape, or form, including maybe emergency, is possibly also important, where you can imagine a case where somebody has pneumonia and the severity is 1, so they tell you to go to the central lab, and then 3 days later, the patient is much worse. And so the patient actually goes to ED and gets treated before the sample comes back from the central lab. So I think that sort of repeat visits, etc., is more of a reality that needs to be modeled. And we didn't do that. That's an important, useful extension that can be done relatively easily, in the sense that it will require quite a bit of coding effort and calibration effort, but it conceptually seems like something doable and should be done.
Great, thank you. And Renata, if you'd like to give us one more question, and then we'll make sure we're respectful of everyone's time and wrap up quickly, but let's take one more, please.
We have one that says, oh my gosh, sorry, I like zoomed in. Who is like the end user of this framework, and how can they use it at scale in making testing infrastructure decisions, and do the results scale universally? And then kind of off of that, do you think that it's only applicable in like the US health system, or in another country's kind of health system? Could the simulation be done?
Yeah, thank you for those questions. Those are interesting. So I think the users are pretty clear. The users are the folks in the hospital management or the healthcare system management who are responsible for making these important decisions of the testing regimes to choose. I don't think this is individual clinicians that we're going to target here. Although one could potentially imagine making some choices sort of downstream, where you can imagine certain systems, maybe not in the US, but elsewhere perhaps, where there is a choice between a less accurate but faster on-the-spot test versus a more accurate but slower central lab test that can be done, and the physician could potentially choose between them. But that was not something that we tried to do here, because that, by the way, is an interesting research direction, because that opens up the possibility of maybe the physician probabilistically choosing between 2 different options. That's not something that we did, and so our focus is not so much on that decision making, but it's more on sort of decision making at the healthcare management or hospital management level. And then this was all based on US data, but I would imagine that with some tweaking, definitely we'll have to adjust the parameters, no doubt about it, if you want to use it in another country's context. But other than the parameters, there might be certain workflow related things that may have to change. For example, our modules are reflective of the typical, not even majority, but the typical US clinical setting, where you have, new patient, established patient going in, then waiting for nurse, waiting for doctor, that sort of workflow. It may or may not be reflective of many other countries. I know some countries where it's not reflective. So yeah, I would say it depending on which country we are talking about, it will definitely need parameters recalibration and quite likely some adjustment to the structure of the simulation platform itself.
So I want to be respectful of everyone's time, and I know that we promised a 5:30 stop, and so I appreciate your all being a little flexible as we get this started and being flexible as we figure out Zoom. But most of all, I want to thank Vikrant, and again, I'm sorry that we can't thank you in person, but we'll be sharing your work and looking forward to hearing future updates at some point soon. And with that, we hope to see all of you next 2 weeks. So next Monday is Labor Day. So our next class will be in 2 weeks, and you're all invited back. Thank you. And thank you again, Vikrant.
Thank you so much for having me.